My name is Paul Enochs. I'm a bariatric surgeon in Raleigh, North Carolina. And I want to thank SAGES for the opportunity to present our data and to show our experience with the single anastomosis duodenal switch technique. Here's our disclosures. Proctor for Medtronic and Intuitive. So when talking about bariatric surgery, as we all know, the numbers of bariatric procedures that we do nationwide have been increasing. And as they have been increasing, what we notice is there's been a propensity toward restrictive procedures at the expense of the band and the bypass. But you'll see that over the last 5 years and beyond, malabsorptive procedures, specifically the duodenal switch, has been basically staying steady at 1%. As a result, when we look at these procedures, though, and we look at the weight loss over time, we see that the sleeve gastrectomy has almost the most variability of all these different types of procedures. As far as the duodenal switch, you see the best weight loss compared to the established procedures that we have. And so as a result, given this issue and the problem that we see with restrictive procedures and have seen in the past with VBG and other procedures, Dr. Torres, about 10 years ago in Spain, looked at adding malabsorption to the sleeve and make a modification of the duodenal switch with a single anastomosis duodenal ileal bypass with sleeve. In his procedure, he started with a 200 centimeter common channel that then moved up to a 250 centimeter common channel and showed a 95% excess weight loss at a year with similar weight loss and metabolic improvement as the two anastomosis duodenal switch. This procedure has since come over here to the US and has gone by many names: single anastomosis duodenal switch, loop duodenal switch, SIPS procedure. But basically the procedure involves doing a loop duodenal aneurysectomy 300 centimeters proximal to the ileocecal valve over a 40 to 46 French bougie. The way we do this procedure is when we go in laparoscopically or robotically, we tack the small bowel 300 centimeters proximal to the ileocecal valve. We mobilize and transect the duodenum, and after we transect the duodenum, do a single layer hand-sewn anastomosis to create the duodenal ileostomy. After we complete the duodenal ileostomy, we then do the sleeve over a 40 French bougie. So in evaluating our procedure, we basically looked at 150 primary SAS procedures in our practice. It's important to note that we are a practice that did primarily sleeve and gastric bypass before 2014. We were not a duodenal switch practice. And so we did a retrospective analysis of our initial experience, compared it to primary bypasses and sleeves we did during that time, and then compared it to established duodenal switch data that's in the literature since we weren't a duodenal switch practice. Looking at the patients that we did during that time, we did 150 SADS procedures, 254 sleeve gastrectomies, and 168 gastric bypasses. The demographics were basically the same, except for the SADS procedures tended to be a little higher in weight. When you look at the weight loss over time, we do see initial weight loss that's comparable among all of them. But when you look at percent excess weight loss, although at 6 months, the weight loss is about the same, when you get to 12 to 18 months, you see the differentiation when it comes to excess weight loss, such that at 1 year, you're looking at close to 86, 87% excess weight loss with the SADS, mirroring the duodenal switch results. BMI drop, we see 20 points of BMI drop with the SADS procedures, again mirroring the duodenal switch data and separating itself from sleeve and bypass. Percent total weight loss, we see 40% total weight loss at 18 months, again mirroring the duodenal switch data and separating itself from sleeve and bypass. And finally, when you look at some of the comorbidities, specifically diabetes, 54 of our patients were diabetic. At 12 to 18 months, only 2 patients were still on medications, demonstrating close to 96% resolution when looking at medications being taken. Again, comparable to the duodenal switch. So this supported our fact that we are doing a malabsorptive procedure, data that showed that was similar to the duodenal switch as opposed to sleeve or gastric bypass, but everybody always knew the duodenal switch had good weight loss and diabetes resolution techniques. The problem comes in with the complications, potentially vitamin deficiencies, and that is why the duodenal switch is about 1% of the procedures being done. So we looked at that. When you looked at readmission rates over the first year, we saw that our SADS procedures at 10% was a little bit more than sleeve, but much better than our bypass data and much better than the duodenal switch data in the literature. And you look at that across the board. When you look at our reoperation rates, we saw primarily EGD being the primary intervention that's done over the first year. But again, our SADS procedures were a little bit higher than our sleeves, but improved compared to gastric bypass and duodenal switch. And finally, when you look at vitamin data, because this has always been the one that patients have thought and that surgeons have thought was the issue with duodenal switch. You do see that when it comes to the traditional DS, when it comes to the fat-soluble vitamins, close to 50% abnormalities at 12 to 18 months. What we found, although we saw slightly increased abnormality when it comes to vitamin A, for D, E, and K, we saw similar results to our gastric bypass patients. We saw actually improved numbers when it comes to ferritin and B12. Of course, A1C was improved, and we don't see the protein deficiencies that you see with the duodenal switch. So at least with our experience, why do we like the single anastomosis duodenal switch? We found that in our experience, it's showing better weight loss and diabetes resolution compared to the sleeve and the gastric bypass. With one anastomosis versus two, it has less risk than the other procedures that seem to be that have malabsorption. Technically, it's easier procedure to perform than the traditional duodenal switch because you're not making the ileoileostomy. The 300 centimeter common channel, there's less incidence of diarrhea and malnutrition compared to the traditional DS. And finally, if you do need to revise this procedure, it's an easy procedure to revise to lengthen the common channel. In conclusion, the SADS is a novel procedure with promising results that can be implemented into an established bariatric practice, even one that does not perform duodenal switch in the past. Readmission, reoperative, and vitamin deficiencies are comparable to the other procedures that we have in our armamentarium, but EWL and comorbidity appears better than both sleeve and gastric bypass. Do agree that further long-term follow-up and studies will be instrumental in establishing this procedure in our bariatric armamentarium. Thank you.
So I have a question. How do you measure the 300 centimeters of the common channel?
We count it. We don't use measuring tape or suture or anything like that, just count it out. And we have measured at times to actually, with the suture to see how close we are. And it actually has been fairly close. And it's the same technique we used to measure when we did our Roux-en-Y gastric bypass and all the rest.
From Norman. Two questions. One, do you close the mesenteric defect? Any concerns for internal hernia? And the other is, do you recommend supplementation similar to a DS or a gastric bypass? Are you telling them to take an ADEC or just a bariatric multivitamin?
Right, great question. As far as the internal hernia defect, because that is such a large space, when we just bring the loop up, we don't close that space. I understand Peterson originally described his defect with the loop, but in our experience now, we have not seen that. And looking at other practices that have done the duodenal switch, the SADS technique, we don't see that internal hernia defect issue like you do with gastric bypass and others. As far as vitamins, we do recommend what we would recommend for a duodenal switch patient. Bariatric Advantage made it a little easy with Bariatric EA, just take 2 of those and some calcium, it gives you everything you need.
Thanks.
Hi, I'm Kalpesh Jani from India. I just want to know that what are your sleeve sizes when you do a sleeve gastrectomy versus when you do a SADS?
Very good question. When we do a traditional sleeve, we usually use a 36 French bougie. When we do our SADS, we do a 40 French.
How do you choose which patients get a duodenal switch versus a bypass or a sleeve?
In our practice right now, when we discuss with patients, I personally believe that unless a patient specifically wants a gastric bypass, really severe reflux Barrett's are the main indications for gastric bypass. I think sleeve is a great procedure if their BMI is less than 45 without major comorbidities. Anything outside of that, I think malabsorption is warranted.